All right, Carolyn. So walk me through when you're worried about compartment syndrome, your exam and evaluation.
So if a patient comes to clinic or to the emergency department and they're present with pain, right? Typically that's the most common presentation is like my limb hurts, right? So let's just say they came in for leg pain, right? Their leg is on fire, it's burning, it's incredibly painful. The complete history and physical, of course, is what you start with, right? Mm-hmm. When did it start? How long's it been going on? And then associated signs and symptoms, right? So in orthopedic emergencies, there's a few things that you're like, I immediately need to look at these things and make sure that they're not present, right? In our rounds today, we talked about compartment syndrome. So a way to rule out compartment syndrome or to evaluate for compartment syndrome, we're looking at the amount of swelling that the patient has, pain out of proportion with their exam. So typically someone who has compartment syndrome is in excruciating pain. It's not subtle, right? Despite medications, there's still uncontrolled pain, right? We check for pulses, sensation, look at the color of the skin. Often in compartment syndrome, there'll be pallor, decreased pulses, marked pain and swelling are the main findings, though.
And what's your process if you suspect like compartment syndrome? Like what do you do as let's say as a emergency medicine provider?
Kind of depends on what they came in for, but usually we'll start with plain films. We'll always look at the bones, right? So plain X-ray I would get of the extremity, and assuming it's an upper or lower extremity problem, right? I'd get blood work. Oftentimes we're looking for like evidence of infection on the blood work, inflammatory markers, and depends if they're on blood thinners. We might be checking like coags, and then it's really a clinical diagnosis though, right? So if you look at the patient, they're in excruciating amount of pain, they're swelling, the compartments are very hard, then the treatment is take them to the OR. So it's a pretty quick call to an orthopedic surgeon while you're working the patient up.
Yeah, for sure. And one of the things, like, I feel like I get calls all the time with, compartment syndrome as the concern. And I think one of the tips and tricks in terms of the exam is if you have swelling in one isolated area, it might be a little bit firm. Maybe you have some induration from like an infection. It might be a little bit like firm or feel in a single spot,
right? As
opposed to throughout the whole compartment. And so, like the compartment is like a balloon. You can't really have isolated, super inflated part of the balloon, and then the rest of the balloon is not inflated. So the compartment pressure throughout is equal and the same, but.
So understanding where those compartments are is pretty important, so you can say whether or not you're like swollen or tight throughout the entire compartment, right?
Yeah, and one of the concerns in the leg is that you have the deep posterior compartment. So you have the anterior and lateral, which are pretty straightforward, and then the posterior, and then the deep posterior. So it's totally possible to have, exam where you're pressing and you're like, it's soft and compressible, and it might be superficially in the posterior compartment, but it might be not in the deep posterior compartment. So just one thing to be aware of.
So in that situation, do you think you'd use a striker?
Depending on the situation, if the patient had a fracture and we already had to go to surgery, or there's another emergency, you may just open it up and release it. But that might be a scenario where like a striker needle would be helpful to place in the deep posterior compartment. The diagnosis is clinical though, so even a striker needle, unless you have image guided striker needle, like how do you know for sure you're in the deep posterior? And fair. Like how do you know you're not abutting like the bone or just like right against the fascia, and it can artificially elevate the pressure. So there's some errors in the striker needle evaluation too. There's some room for error.
Yeah, for sure. So we also chatted about fractures today, right? What would you say associated with fractures makes it an urgent or emergent situation that gets you out of bed to hustle into the ER?
So anytime a fracture is open, bone poking through the skin, or like a laceration where the bone may have poked through the skin and then got back into the extremity. So an open fracture, a fracture associated with an infection, a dislocation, any sort of nerve or vascular compromise are the ones that kind of immediately, come to mind. All of those are limb threatening. So one that can develop into a compartment syndrome is limb threatening. An open fracture can get infected and affect the viability of the limb. A dislocation can ruin the joint extremely quickly. So if that joint isn't centered, you can cause arthritis over the short term. Infection can destroy the joints. And so all of our orthopedic emergencies are always tied back to the health of the limb is immediately threatened, like over the course of hours, not like weeks, years, and beyond.
Yeah, so when you're talking about infection or dislocation, and you say it's the time is short, you mean hours short. You have hours to address this issue, right?
Sorry, ask the question again. I got a text message.
I saw that. So when you were just saying...
Ask me again. I didn't understand the question. Ask me again.
So when you're saying that... oh my gosh.
How annoyed are you going to be at me when I pretend not to hear you this next time?
I will just stare at you.
That is the worst punishment.
So you were just saying that if there's an infection or a dislocation, you have to address it quickly. What's the time frame that you have to really address these issues?
So for an infection in 8 hours, you start to get irreversible damage to the joint. And in a day or two, it could have complete destruction of a joint from a joint infection. And the compartment syndrome or other things also equally fast. A dislocation probably a little bit longer, but a joint that's out of joint for weeks on end is tough. The thing about the dislocation that makes it a little bit more urgent is the joint wants to be reduced and wants to sit reduced. And it's the lowest energy. It's like law of entropy. That's like the lowest energy. But if it starts out and then the soft tissues start to condense and shrink and collapse, then it becomes extremely difficult to get it back in. So one of the reasons why a dislocation is so urgent to get in is because it's going to be the easiest right now. And the longer you wait, the harder it's going to be, and the more invasive surgery is going to be required to get that joint back into place. And we use the word reduced, meaning that the joint is now like back together. It was separated or dislocated, and now it's back together.
We've definitely seen that in our practice, right? With joints that we get called to the ER and reduced quickly, and ones that chronically were dislocated for months and required aggressive surgery to fix. Yeah.
I have a joke. Just kidding, I don't.
He does not.